Good evening, welcome. Can you hear me all right? Good, I probably won't bother with any microphones then. I'm Donald MacArthur, this year's president of MedChi. I'm very happy to see you all here tonight. Last month's meeting, Dr. Norman McConaughey's presentation on essentially the history of neuroradiology, interventional neuroradiology, that's now available to see on YouTube for anyone who wasn't at the meeting and would like to see it. You can catch up on that on YouTube. Did we have any apologies for absence that were notified to us? I'm not aware of any. And no. Oh yes. Stanco, yeah, yes, so we did. And minutes of the last meeting, as I mentioned, you can see not just the minutes, but you can see the whole meeting online on YouTube. A couple of social events to mention here. One that's not on the slide because it's only recently confirmed, but the MedChi quiz. This year, David Bogod, our question master extraordinaire, again will be putting together a completely impossible quiz. One of the best things about it is it's impossible to cheat. Even if you were to surreptitiously get your phone out and try and look up the answers, you won't manage. So it's utterly fair, virtually impossible, but a lot of fun. And it's in the Embankment Bar, which has a great tradition in sort of healthcare in Nottingham. Many of you might know it's the old Boots Social Club just on the other side of Trent Bridge, and a very nice place to spend an evening, actually. So that's on Wednesday, the 29th of April. And you can enter either as individuals and be put together in a group, or you can enter as a department or a team of friends, or you can go with nationalities. We've had successful Welsh teams and Scottish teams in the past. Very successful Scottish teams, I'm pleased to say. But think about that, get a team together if you can, on Wednesday the 29th of April. And then our other big social event that's coming up that's got a date is the Ball, which we've talked about before, is on Saturday the 16th of May in the conference centre, and it's now possible to book for that via the website, via the MailChimp system. Tickets are £90 per person, which feels a lot, but if you look at everything you get for that, actually it's pretty competitive for an evening like this, because there'll be string music and welcome drink, there'll be a 3-course meal, there'll be dancing to spinal cords, there'll be a casino, there'll be a magician around the tables, and there'll be racing. So not the old-fashioned dodgems where you were at risk of slipping on the mud outside or getting a whiplash injury, and the liability for that these days is unforgivable. But there'll be 4 Formula 1 racing simulators next to one another. So you can get on those along with your friends, and you can try and drive better than them and compare your performance with theirs. And it's all completely indoors and safe and a lot of fun. So a lot to enjoy, I hope, and there'll be tables for 10 or 12 at the Ball, and as I say, you can book now and put your names down and the names of the people that you would want to have on your table. We will have a go-karting competition, which we've been promising for a few months, but we've decided to do that in June when the days are longer and the nights are light, so the date of that will come out soon. A reminder that this year's charity is Doctors in Distress, as it's been for the last 2 or 3 years, and you're welcome to make individual donations to that if you're happy with how things have been at the meeting and you want to, as a gesture, make a donation. That would be gratefully received. The link is on the MedChi website. In about a month's time, we've got Dr. Jerry Dolan, who many of you will remember was a consultant haematologist here for many years and is now working in London and is an expert on haemophilia. And he's going to come and talk about increased understanding of haemophilia in his talk From Darkness into Light on Wednesday, the 18th of March. Before we get to tonight's lecture, we have 2 of our medical students who were recipients of elective awards last year, who are going to give us a short presentation on their electives to tell us what they did with the money, what they got out of it, and what was good and what was bad. And I hope we'll have got lined up Dr. Chloe Weinstock first. I think we're going to be able to see Chloe's slides, and we're going to be able to hear her, but not see her. So I apologise, but that's what Chloe looks like. And you'll hear her voice and see her slides in a minute, thanks to the miracle that is IT. So I'll let you.
Yes, so Chloe, if you could just. Oh, yeah.
Hello.
There. Cool. Yeah.
Hello.
Hopefully everyone can hear me. Sorry that you can't see me, but I promise I've dressed up for the occasion. So I went to Tanzania in June last year, and Medkai like very kindly offered me a bursary for that, and I got a lot out of it. So thanks for having me tonight. I'm very grateful for the opportunity. If you want to move on. Okay, it might be a few slides until we get into it. So I went to Tanzania. I was in the very north part of Tanzania in Moshi, and that is where Mount Kilimanjaro is. So I also quite like film photography, so there's quite a few photos coming up where you might see some glimpses of Kilimanjaro. Next slide, please. So I went to Tanzania because I've always, for the past few years now, I've wanted to do infectious diseases as a specialty in medicine. And I was kind of inspired by Prith, who's one of the consultants in City Hospital, who some of you may know. And yeah, I had a few preconceptions about Tanzanian healthcare. But I think it's fair to say that you can't really understand anything properly until you're actually there and seeing it in flesh. So I knew that their kind of obs and gynae system would be quite different to ours, which I definitely did see. But I didn't quite know what I was going to expect about the hospitals. So next slide, please. So this is me out there. So I was based in a private hospital. I think if I had to estimate, I think there'd be about 80 beds in the hospital. So there were medical wards, peds wards, surgical wards, and obs and gynae wards. And there was also an emergency department. And this hospital also had a primary care element to it as well, which was quite important for this area because there's not that much primary care provision in the city, and it's not highly accessible to most people. So there were GPs in this hospital as well, which was great. Next slide, please. So that's Kilimanjaro on the right hand side. That was just outside the hospital, so it was really amazing. On a bright day you could really see for miles. I went on a little walk up to the base of Kilimanjaro, but not to the top, unfortunately. My trip was not long enough for that. Next slide, please. So one of the things that I really enjoyed from my trip, because I went with the kind of idea that I would kind of deepen my interest in infectious diseases, and I was able to go on a couple of outreach trips to the local Maasai tribes. So the Maasai tribe kind of covers areas of Kenya and also the very north of Tanzania as well. So the Maasai tribe, it was about an hour away from where we were staying in Moshi, and we provided free healthcare just for about a day every couple of weeks to a tribe probably of about 150 people. And it was very important to do kind of HIV and Hep B testing because the tribe has it kind of values having multiple wives. So diseases like sexually transmitted diseases are very easily spread. And when we went, we had 3 positive tests. So actually, I think we were all negative for HIV, but we had 3 positive for hepatitis. And that was a really good opportunity. So it was me, and then there were some local doctors as well. So we could give counselling on kind of what activities to avoid and how to access treatment in the city as well. So that was a really good experience that I enjoyed. But you can see that things were quite basic. So I think that's methylated spirits that we used to sanitize people's hands before we did a finger prick test. So it was basic, but it was again a very valuable experience. Next slide, please. Yes, so HIV testing and treatment is free, but hepatitis treatment is not free. So that is a bit of a barrier to people accessing healthcare, especially with the Maasai tribes where there's no kind of sustained income that they have. But one thing that I definitely saw is a lot of kind of late stage HIV patients. So I saw all of the kind of diseases that you might associate with HIV, like esophageal candidiasis and cryptococcal meningitis. It was all there, and it was really quite well, it was quite distressing to see, actually, I think, because there were lots of cases that you think, would it have got to that stage if they were in a different country, or if there was less stigma around it? But yeah, it was definitely eye-opening. So next slide, please. So these are some of the different diagnoses that I saw. I saw a lot of malaria. It was quite funny because I was doing ward rounds every day with some of the medical team, and they started quizzing me and some of the other medical students on malaria, so some of the local medical students. And obviously I almost never knew the answer because it's not something that we see very often, but the doctor was very disappointed when the local medical students didn't know kind of the intricacies of malaria, because it was just so common in that area. It's especially common in kind of coastal areas and stuff like that. So yeah, so we saw a lot of that, and then a lot of, as I said, the HIV diseases and kind of signs of like progressive HIV infection. So the esophageal candidiasis and the meningitis, as well as the tuberculomas. But I think one thing that's also really telling from these diagnoses was the kind of lack of primary care in the community. So lots of uncontrolled diabetes and uncontrolled hypertension, that meant people were coming in with kind of end stage problems of this, so like strokes and amputations. So yeah, next slide please. Yeah, so I touched on problems of not having primary care in the community, but another thing that I also saw and was a real learning point for me was that there was a real lack of kind of palliative care and ceilings of care. I'm not sure if that's because it's kind of a private hospital, but there were not many conversations of like plans of when to stop treatment. And I saw a couple of resuscitations on older patients who probably wouldn't have been candidates in the UK. And I had a bit of a discussion with the doctor, and he was sort of the mindset that DNA CPRs like just don't exist, and certainly it's not something that he's ever. He said he'd had a conversation with one patient who wanted a DNA CPR and he just couldn't understand them, basically. And he told me that just Tanzanians like to live, and he would always attempt to resuscitate. So that was definitely something that was culturally quite different. Next slide, please. So I wrote a diary while I was away, which did help me make my presentation, and it's a nice thing to look back on as well. So the hospital that I was working in was attached to a nursing school, and one of the differences was the ward round was absolutely massive. So there were literally over 20 people on the ward round at one time, almost every day. And so you can see in that photo, all of the ladies in the pink dresses are nursing students, and then there are a lot of medical students there as well. Yes, so it was very busy, but I suppose that's quite a positive of like, there's a lot of people who are wanting to get into healthcare in that area, so that was good. Next slide, please. So these are some of the learning points that I had. I'm just wrapping up now. So something that I definitely saw was kind of poor access to palliative care, which is something that I've really grown to appreciate in the first kind of 6-7 months of my F1 year. I've seen that used really well, and that's not something that they really had access to in the area that I went to in Tanzania. And also I think the primary care aspect was really important, and that's also not something that's kind of done so well in Tanzania, kind of preventative healthcare and stuff like that. So yeah, next slide please. So yes, sorry, it's just come onto my screen. So these are different things that I'll kind of implement into my practice. So I know a little bit more. I definitely know more about malaria, but also a bit more about how to treat people who are from different countries and from different areas, and like the cultural dynamics that I think are different to what I've experienced in the UK. And I think I can use some of the ways that they communicated, like to use that with my patients who have come from different areas and immigrated over to the UK. But I've also definitely learned about the privilege that we have here of dying with dignity. At least that's the aim, and the importance of funding primary care, especially for preventing these end stage diseases, basically. Next slide, please. Yes, so I think we're kind of at the end of the presentation, to be honest. There's just a few film photos of the actual area that I thought people might like to see. Everyone goes around on these, they're called bajajis, they're like tuk-tuks that absolutely race around all of the streets. So yeah, you can just flick through the rest of the slides and they just have a few photos of, like, there was a football match that we went to. This was at the Maasai tribe. And yeah, that's the end of my presentation, but I really feel very grateful for kind of the doors that the bursary opened for me, and I got a lot out of it. I mean, there's lots of things that I still look back on now, even kind of 7 months later, and will continue to for the rest of my career. So I'm very grateful, and thank you very much.
And thank you, Chloe, for that lovely presentation. From Africa to America now. Is Ronnie online as well? We've got Dr. Ronnie Altman, who went to Peru with the Amazon Hope ships.
Hello, everybody.
Oh, hello.
Hi.
Hi, Ronnie. Hang on till we just get your pictures up.
Oh.
I think we can see your first slide now. Can you see it as well?
Yes, I can.
Perfect. Take it away.
So hello, everybody. Sorry I couldn't be in person to deliver this, but yeah, I'm very excited to be able to speak about my elective. So for my elective, I took part with the Amazon Hope Project with the Vine Trust, which aims to deliver primary healthcare to underserved communities in the Amazon rainforest. The programme itself was based in the Loreto region, which accounts for 28% of Peruvian territory. So that's like the photo in the top right. The capital of this region is Iquitos, where about 45% of the population resides. The latter 55% are spread out across approximately 2,000 remote river edge communities along the Amazon. These areas have no road infrastructure and so are only accessible by boat. I did initially include a photo of the map to reference this and was going to point out where Iquitos was. Might be a bit difficult to do virtually, so well done to anyone who could spot it. But each of the little dots represents a different Amazonian community, so you can just see how spread out everything is. Next slide, please. So initially I was drawn to this elective because of the location. The Amazon rainforest and South America more broadly felt like an opportunity to experience something which was culturally very different to anything I'd previously experienced. I was also particularly interested in how culture, especially one so different to anything I'd experienced, influences the way healthcare is delivered, and as how someone who is so external from that culture could both learn from it and think about how to practice medicine respectfully within it. I also wanted to better understand the barriers these community faces, in accessing healthcare, particularly in the logistical challenge of delivering care to geographically isolated populations. This felt especially important in such a resource-limited setting, where decisions often have to be made without infrastructure I'd been used to in the UK. And finally, I also wanted to push myself out my comfort zone and broaden my perspective on what healthcare can look like outside systems I'm used to. Next slide, please. So during my elective, as I mentioned, I quickly learned that geographical accessibility was one of the major barriers to healthcare in this region. So many of the communities are only accessible by boat, and travel conditions are very dependent on the river level, which varies throughout the year. So in low tide, these communities become even more inaccessible. Travel to Iquitos, the main capital city of Loreto, where most medical services are located, can take hours or even days by boat trip. So I'm sure you can appreciate when there are no roads, healthcare provision is even more challenging. Next slide, please. Another healthcare barrier these population faces is structural. So I guess very quickly, the Peruvian healthcare system is split into three parts. There's the private healthcare system for those who can afford it. Salud, which provides healthcare to those in formal employment. However, this is largely based within capitals of provinces such as Iquitos and only available to those who work in governmental positions, so teachers and doctors, etc. The final healthcare system they have is Sistema Integral de Salud, which is a state-funded public insurance scheme designed to cover lower income populations. So this covers the majority of the population outside of Iquitos in Loreto. These are not often well implemented or well supplied, especially in this region. And they often exist as health posts, which are usually staffed by nurses or often technicians. So how did the Vine Trust begin to address these barriers? So the Amazon Hope is the floating primary care clinic, which aimed to bring the services directly to communities along the river. It's staffed by a number of different healthcare professionals, so Peruvian clinicians and international volunteers as well. I think it kind of involved doctors, dentists, pharmacists, healthcare assistants, sometimes midwives. The other thing was that the Vine Trust, so we also worked with the Peruvian government to run healthcare campaigns and educational programs, such as the Glasses campaign, where we were testing vision and distributing free glasses to patients, alongside health education in local schools, which cover topics like oral hygiene or contraception. Next slide, please. So each day typically consisted of 2 different clinic blocks, one in the morning and one later in the day, with time in between to travel between the different communities. Clinics took the form of traditional GP type consultations, similar to the UK, and common presentations just included anemia, which was prevalent in over 55% of kids under 5, gastrointestinal issues, fever, viral illnesses, and skin rashes. In the evenings, we were often able to visit the local villages, which was a valuable opportunity to interact with the locals outside of the clinical setting, usually over a game of football or volleyball, which we consistently lost every single time. Next slide, please. One of the most important exposures for me was the interaction between culture and healthcare. So in the Amazon, specifically in the communities deeper into the Amazon, there's this interaction between traditional and plant-based medicines, which plays a significant role in how healthcare is delivered over there. So on the slide on the left-hand side, that's a photo of a tree that grows in the Amazon, and they take the sap, it's called dragon sap, and it's used locally for a number of perceived therapeutic properties. So from promoting wound healing to even staunching diarrhea, or even sometimes as treatments for hemorrhoids. I also found that culturally, illness may also be interpreted spiritually as well as physically. So, for example, we had this one patient who worked as a shaman, and he mainly presented with scabies. But interestingly, he described this as like a physical manifestation of the mental struggles of one of his clients, which had passed over to him during one of his ceremonies. Next slide, please. So practicing in the setting, as I'm sure you can all appreciate, felt very different. There was effectively no way to safety net patients, no guaranteed follow-up, and very limited diagnostic testing. This required very careful listening, thorough history taking, and ensuring you can try to make the safest decision in the moment. Medication stock also was very limited and dependent on availability, as the ship could not restock once it had set out. So prescribing demanded a lot of caution, because not only did you have this very variable stock of medication, but if you were over-prescribing this medication, sometimes it could be used as currency within the communities themselves. Overall, though, I think one of the most difficult challenges was sometimes we simply couldn't offer solutions to people. So another example was we had this one patient, she presented with kind of firm fixed masses in her neck and in her abdomen. We had an ultrasound on board, and we kind of scanned these, and this was interpreted by a Peruvian doctor who said it was likely malignant. But unfortunately, the only way for her to even get kind of any formal scan to further kind of diagnose this was days boat trip to Iquitos, and from there, specialist cancer services are only available in Lima, which is a 2-hour flight away. So these kind of highlights the kind of further financial and geographical limitations to the population who live there. Despite all these challenges, though, all the patients who came on the boat all had like so much gratitude, even for consultations where all you did was just reassure them that they just needed to drink a bit more water. And I found that was quite deeply humbling as well. Next slide, please. Thank you. So going forward, I found that this experience broadened my cultural perspective. I recognise that sometimes the way patients view illness is very different to how we were trained to here in the UK. Also, working in a low resource setting reminded me the importance of clinical examination and history taking. It also made me more aware of how structural inequality might shape healthcare outcomes, particularly the case when access to healthcare determines opportunity. And at the same time, it made me very appreciative of the UK healthcare system, especially now that I've started working in it as an F1. And finally, it sparked a genuine interest in remaining involved in work similar to this that addresses healthcare access and inequity in the future. Next slide. Thank you. Okay, so this is my final slide. I just wanted to thank everyone for your generous contribution. You made this entire experience possible for me. And as Chloe said, this was completely, I'm just very appreciative, because I think it definitely will inform how I shape healthcare in the future. Thank you very much.
And thank you very much, Ronnie. So you're both welcome to stay and listen online. Tonight's main talk is a joint meeting with the Vale of Trent GP faculty, which we do once a year. And we thought something interesting to do this year would be to look across hospital and primary care medicine about the future of training. And I'm delighted we've got here to talk to us tonight Professor Jonathan Corne. He's a respiratory physician by training, graduate of Cambridge and King's College London. He carried on his training after that in research in Southampton and spent a year in Yale. Still has, I think, 2 sessions of clinical respiratory work per week in Nottingham, but most of his time is now dedicated to education and in particular postgraduate medical training. He's held a lot of posts over the last few years in relation to this. The highlights currently are that he's the local dean for the East Midlands, at the regional postgraduate dean for the whole of the Midlands, East and West, and he's the lead dean for a number of specialties and for flexible training. So knows a huge amount about what's going on in training. I think there's a lot going on in medical training in the last few years, it's fair to say. There's been some of the fallout from the government's plan to double the number of medical school places by 2031 and promises and things like that we're all trying to deal with and work out where they're all going to get foundation jobs and so on. There's been the medical training review last year, which has asked a lot of questions and created a huge bank of information, but it's not entirely clear where things are going with that. And then just this year, there's been the medical training prioritisation bill, which is something that's appeared very quickly and is going through very quickly, and it's probably going to have an impact. So I think it's a really interesting time to address the future of medical training. So without further ado, we'll ask Professor Corne to come and tell us, how will we train the doctors of the future?
And as is readily apparent, I have not dressed for the occasion, I'm afraid. So I'm going to start with a picture taken a long time ago. This is me as a medical student, sitting in the middle here. And if I look back to when this picture was taken, a lot of things, sadly including my weight, have changed. But I remember, I'm sure some people in this room remember, having to admit people to hospital to start them on ACE inhibitors. Sounds incredible nowadays. I remember the first line investigation for an intracranial bleed was a skull X-ray. Again, sounds incredible these days. But despite those huge changes, I think you can argue that the very essence of medicine has not changed, and that any of the people sitting around this table, if they looked ahead to the clinical job they're doing now, they would recognise it. And that's not surprising. I mean, when this picture was taken, the doubling time of medical knowledge was still a sedate 7 years. That doubling time is now said to be 73 days, and technology across the board is changing hugely. So it's very difficult, I think, for any medical student now to confidently predict what their job is going to look like in 10, 20 years' time. And I think, therefore, we need to take heed of what this person said. So Jean Piaget was a Swiss cognitive psychologist, I suppose these days we'd call him an educationalist, who said that the principal goal of education should be creating men and women who are capable of doing new things, not simply repeating what other generations have done. And of course, in medicine, we have to do both, don't we? Because you have to train people who can hit the ground running when they get their CCT, but we also have to train people who can respond to change, who can innovate, and who can lead change. So with that in mind, I thought what we could do is talk about, first of all, who we train, then what we need to teach our resident doctors and GPs and consultants of the future, and then finally how we train. It's going to be generic because there are quite a few different specialties here. I'm going to talk a little bit about the procedural specialties at the very end. And I should say that these are my views I'm talking about today. So let's start with who we train. I want to talk about numbers, I want to talk about diversity, and I want to talk about generational change, because obviously if we're going to train people, that training has to fit in with the values and beliefs of the people that and desires of the people that we're training. And spoiler alert, it doesn't, but we'll come back to that in a minute. So the numbers story is actually very good in the East Midlands, where we've seen increasing numbers in both GP trainees and in secondary care trainees. So this graph at the top left shows you the national picture when it comes to the number of GP trainees we're recruiting to each year, and you can see there's been a steady increase. And then on the bottom right, you see it's been a bit more sporadic, but nevertheless quite an impressive increase in the number of GPs that we recruit every year. The graph hides it slightly, but essentially we're going from about 270 a year, which was 2018, to about 370 a year. So quite a significant increase, and one that's likely to continue for the next few years. It's not, of course, just about increasing the numbers. We have to get people interested in general practice. And you will probably know that the medical schools now focus a lot more on general practice. Some medical schools have been built recently with an objective of training mainly general practitioners. And also the aspiration is that in the future, by I think it's 2031, every foundation doctor will do at least 4 months of general practice in their rotations. And that does cause challenges, of course, of capacity. Because if we're having more students doing general practice and more foundation doctors doing general practice and more general practice trainees, we need the estates in which to teach them, and we need the educational faculty with which to supervise. And so we may have to think of changing the way that we deliver general practice training. We may need to move from more local teaching to kind of wider, more regional teaching. Blended learning is something we're doing at the moment very, very successfully. And that's a mixture really of face-to-face teaching, webinars and online modules. It's been very successful actually increasing our exam pass rate. We may even have to think of shift working. So you're not in the general practice all day, but you do part of it and then someone replaces you in the other part of the day. Being proactive with exam support, which is something that our school are very good with indeed, avoids people failing and having to extend their training. So that creates capacity. And then, of course, we need to make full use of the multi-professional team to educate and to train our GP trainees. The good news, though, is that we're going to have no problem getting these people, because the East Midlands, and this is a graph of application rates, application numbers, I should say. The East Midlands is the black line. Ignore 2025 because the recruitment system has changed slightly, but you can see that partly because of the work I've just described, we have moved from being probably the least popular deanery in the country for general practice training to second only to London, which is really tremendous achievement, and thanks to all the people here that have been involved in training our GPs. In secondary care, we're also seeing an increase in the workforce. So we've seen a redistribution of national training numbers away from the higher doctored areas like London to the regions. We've seen probably an increase of about 200, 300 NTN numbers in the East Midlands as a result of that over the last few years. And we're also seeing specific expansion in posts related to cancer and diagnostics. We're waiting for the government's long-term workforce plan. That will come out about May time. But what they did say in their 10-year plan was they want to recruit 1,000 more specialty, want to create, sorry, 1,000 more specialty training posts over the next 3 years. And as you know, that ambition now is probably to do it over the next year. That's kind of tied in, as you would probably know, with the industrial action. As Donald said, they want to prioritise UK medical graduates. In fact, to be exact, it's graduates from the UK, Ireland, Liechtenstein, Norway, Iceland, and somewhere else I can't remember, refocus generally recruitment away from other countries. And that's not just because people in this country are not managing to get jobs, but actually recruitment from other countries, especially developing countries, is not really sustainable. There's increased competition for those doctors and there increased needs for those doctors in their home country. So quite a positive picture, I think, when it comes to numbers, especially in the East Midlands. What about diversity? Well, this was my medical school clinical year, and actually we were a fairly homogenous lot, as you can see, predominantly white and almost exclusively middle class. Now, medicine's become a lot more diverse, luckily, since then, but the one area where we haven't really made sufficient inroads is in socioeconomic diversity. So if you look at the graphs on the left here, this is plotting essentially affluence on the x-axis against the numbers of people that apply to medical school. Essentially, you can see that if you come from a rich family, or the richer you are, the more likely you are to apply to medical school. And if you look at the graph on the right, and the green line is those people who enter medical school from the lowest socioeconomic groups, despite huge amounts of work from medical schools like Nottingham. Lincoln, remember, was built as a kind of winding participation school. Despite all of that, there's been real little change in the number of people from the lower socioeconomic groups that enter medicine. There has been some improvement. So the number of schools producing medical graduates, producing medical applicants has increased a bit, and the proportion from state schools has increased a bit. But still, a third of the schools in this country have never had anyone in them that has applied to medicine. And that is problematic. It's problematic, firstly, because we're missing a pool of people who would probably be quite good. But also there are some very under-doctored areas in this country, which tend to be those areas that are most economically challenged. And we know that one of the biggest determinants of where someone ends up working is location of friends and family. So if we really want to train doctors who are going to work in some of these most needy and deprived areas, we need to recruit to medical school people from those areas. And so there's been a lot of talk over the last few years of increasing the routes of access into medical school. So people have talked about the idea of a 4-year degree, which is clearly financially a little bit more manageable, though academically a little bit more challenging than the 5-year degree. People talk about apprenticeships. The last government was very keen on apprenticeships in medicine, and a lot of these apprenticeships were combined with kind of virtual medical school teaching from the University of Plymouth, but that's currently on pause. And there's also this concept of APL. So the idea here is if an allied health professional enters medical school or goes into medical training, they can discount quite a significant amount of time because of the experience and the knowledge they already have. Now, I'm not sure if any of these are actually going to fly, but I do think that we will see over the next 5 or 10 years an increased diversity in routes of entry into medicine, because that's the only way we're going to solve this problem of getting economic representation. And then, of course, as I said before, we have to have a training program that fits the needs and wants of the people we train. And you will know there's been a huge generational change. So this is a paper from Ireland, where it's a qualitative study where they asked GP trainees what was it they most admired in their supervisors. Okay, and this is a nice quote here. This person says, the GP who did my 18 weeks, that I did my 18 weeks with was brilliant. They're 100% committed to the job. It wasn't just a clock in, clock out situation. It was more a way of life. That's a really good testament. It goes on to say, to tell you the truth, I wouldn't want that. I would take the hit on my professional life. I would prioritize family or personal life over work commitments. Now, that's not a bad thing. I mean, very few people retire and say, I wish I'd spent less time with my family. It's actually quite a good thing. Okay, and it does represent what we know about generational change and the attitudes of what is called Generation Z, the people who we're currently training. So they do value family life, but they're also very pragmatic rather than idealistic. They're very diverse minded. They're very individualistic. They have a strong sense of personal expression and they value flexibility. So what we're doing at the moment, we're taking people that value family life, and in some areas of the country, we're rotating them around hospitals 2 or 3 hours drive away. And we're taking people who are pragmatic, who are diverse-minded, who are individualistic, and we're kind of putting them through what you could consider a kind of sausage machine of medical training, all going through exactly the same training pathways to produce a kind of identical sausage at the end of it. And funny enough, that doesn't work. And it's caused a lot of discontent. There were very good reasons for developing this kind of training, because training beforehand used to be a bit laissez-faire. But this is no longer working. And as a result of that, NHSE launched the medical training review, which Donald alluded to at the beginning. And this is actually very impressive. I mean, it's the largest review of postgraduate medical education ever undertaken, I think, anywhere. They talked to over 7,000 people, huge numbers of focus groups, huge number of stakeholders. And I think the conclusions were not that, were pretty obvious. So training must be more flexible. There needs to be ways of attaining excellence without going through formal training programs. The current training bottlenecks are damaging. And actually, as anyone in the hospital knows, we need to rebuild inclusive team structures. I think we could have guessed that. We're now moving from the diagnostic phase to actually the solutions phase. And the MTR is going to continue by working through a number of themes, and they're working groups for each of these. And it's, as you can see, it's quite wide reaching. So we're going to be talking about career progression, educators and facilities, curricula and how curricula change, procedural heavy specialties, flexibility, delivery of training, academic medicine and rotations. The official launch of this phase is going to be in May, but we have started working on some of these areas already. And let's just take as an example flexibility. One of the big things at the moment is there seems to be a lack of flexibility in training. So I think this is going to change. I think in future we're likely to see a lot of people just doing non-training posts and becoming SAS doctors, very much as a positive career choice. we'll see people going through the standard training programme, but more and more, I think we'll see people going in and out of training posts. We actually have that at the moment. We actually have what's called UP, which is a pause in training, where someone can just step off the training ladder, remain in a training programme, but do a non-training post for a bit, just because they're fed up with the kind of assessments and things that you have to do in training. And I think we'll see people moving in and out of programme, which is fairly prescriptive at the moment. You have to do research, education, out of programme. I quite like the idea of calling out a programme sabbatical and letting people do whatever they want in that period of time, whatever they feel they need to do to either explore their career further or recharge their batteries. And one of the things we are working on is what we call a capability passport. So whatever you're doing, whether it's in a training program or a non-training program, whether it's clinical or non-clinical, you can use this app to record the capabilities and competencies you've got, and you can then transfer it to your electronic portfolio. But of course, there's a big caveat to this. And the caveat is that not only do we need to fulfill the needs of the doctors we're training, but we do need to deliver care for the population in the areas it needs to be across the country. None of our trainees, for example, want to go to Boston, not because it's a bad hospital, but because it's a 2-hour drive away. Yet we do need to have a training system that delivers doctors who can work in Boston. And I think the challenge of the next few months with the medical training review is getting that sweet spot, if you like, between producing doctors who can and do and want to deliver care for the entire population, and also at the same time fulfilling the needs of those doctors that we're training. So let's move on then to what we teach. What do our doctors of the future need to know? And one of the things we're really good at doing is teaching knowledge, or even better at assessing knowledge. So these are some questions from the part 1 exam of the MRCP. No point in selling them off. These are on the public website. And here, let's just take this question as an example. This is about a woman with thrombocytopenia who's about to have a splenectomy. And the question is, when should she have her pneumococcal vaccine? And you can see the range of options are from 1 month before surgery to 1 month after surgery. It's an interesting question. I mean, if you're appearing on Mastermind with the spleen as your specialist topic, you definitely need to know this. But I can say that I have been a consultant for 26 years, and nowhere, well, at no time during that period has someone come to my clinic and said, I'm about to have my spleen out. When should I have my pneumococcal vaccine? And the point is, if they did, I'd be sitting in front of a computer and I'd be able to look it up. You know, why are we getting people to learn things that you can just look up? Here's another one. This is from the GP exam. This is about how soon after an angioplasty can you drive? Okay, again, you can just look this up. In fact, what must be really irritating, so that I looked it up, there are 118 medical conditions that are covered by the DVLA guidance. So first of all, why you are asking about this one? You know, people expect to know all 118. But the other really irritating thing, if you're sitting in this exam, is the question actually DVLA angioplasty, you get the answer within about 8 seconds. Why are we getting people to learn facts of dubious relevance just so they can go to an exam and prove that they're able to learn facts of dubious relevance? You know, we really have to get used to the fact that knowledge is now available at our fingertips, and we have to be it's obviously important to have knowledge, but we have to be much more savvy about what we need, what we expect people to learn. So what should we be teaching? Well, here's some examples. So quite a high proportion of healthcare now is delivered over the telephone or by video link. Very few curricula at the moment specify that you have to have the capabilities and competence to do telephone consultations. Yet we all know the skills involved in a telephone consultation are very different from the skills involved in a face-to-face consultation. I mean, clearly you can't examine the patient. Difficult to get the kind of nuances. The patient might be sitting in a room with family members all around them. You know, there's a very, very different skill set in doing that. Social media. So we think of smoking, don't we, as the big hazard as far as health is concerned, but social media is becoming an increasing hazard. How do we deal with the person that comes to our GP surgery or comes to our outpatient clinic and won't have a treatment or won't have their child vaccinated because of something they've seen on social media? We really need to start teaching people how we kind of deal with these scenarios. Genomics, government's very keen on pushing genomics. Okay, so there's the kind of rare disease genomic stuff, but there's also the rare causes of common diseases that we see all the time. They're the ethical considerations of genomics. What about the person that comes to the GP practice having had a private genomics test and wanting to know what to do about it? There's AI. We're going to increasingly use AI in clinical care. We need to teach people what the limitations are, things like algorithmic bias. Need to be, this is going to be fundamental to using the technology correctly. And then there's empathy, and that might seem to be a bit of a funny thing to teach, but this is work by Jeremy Howick, who's actually coming next year to speak here, who runs the Stonygate Centre for Empathy in Leicester. And this is, he has shown that actually if you take medical students, as they enter medical school, they have high scores for empathy. As they leave medical school, their scores have dropped significantly. And that's not surprising, really, is it? Because they're surrounded by people like us who are hassled all day long, okay? They're in a stressful work environment. There's lots of time pressure. And what he's also shown, though, is that you can teach empathy. So he's shown that by teaching empathy within Leicester. But in this meta-analysis here, he's shown good evidence that empathy, or at least appearing empathetic, there's a slight difference between the two, of course, can be taught. Now, I would have thought the decline in empathy that happens in the undergraduate years probably reflected in the postgraduate years. I don't think there's any proof for that, but maybe we should be incorporating empathy training into our postgraduate training as well as our undergraduate training. In secondary care, of course, there's a need for more generalists. And that's been the trend over the last few years. As you know, most curriculum are now emphasise generalism a lot more. But there's so much more multimorbidity nowadays that getting a patient looked after by 4 or 6 different specialties in a hospital is time wasting, and is no good also when the patient gets discharged and the GP gets 5 or 6 different versions of what's going on. So we've been emphasising a lot more in the medical curriculum, for example, the general medical skills that a consultant needs to have. And in fact, we do have some people training in the East Midlands just doing general medicine. We are likely to see the return of the general physician. Everything goes round in circles, doesn't it? And that's one of those. And then there's the wider curriculum. Okay, so not just thinking about the patient that's sitting in front of us, but thinking about the community they come from and thinking a bit more globally. Let's think about the community. I'll illustrate the importance here by showing you a taxi journey. Okay, so this is a journey from Bulwell to Woollerton Vale. Okay, it's about 6 miles, takes about 10 minutes. And if you look up the fare, it should be between about 14 and 17 pounds. Now, in that journey, I actually will be moving from a region where the male life expectancy is 73 years to a region where the male life expectancy is 83 years. That's 10 miles away, or 5 miles away, 10 minutes away. And it's a bigger difference, by the way, for healthy life expectancy. So if really we as doctors are going to improve the health of the community as a whole and going to improve morbidity and mortality, we can't just focus on the patient sitting in front of us, because a huge amount of that difference in morbidity and mortality is due to environmental factors. And we need to be able to understand that if we really are going to make inroads into improving health. So one of the things that was launched last year was joint GP and public health training. So this gives GPs some of the public health skills that will help with that. And we also have a number of, we have innovative training placements and Trailblazer fellowships that address these. So the innovative training placements are part of our GP training scheme, where people can do, I think it's 4 months, some of which is in the GP practice, but some of this is working with marginalised groups. So community outreach, exclusion health, which looks at people like asylum seekers type of thing, sexual health clinics. And in the Trailblazer fellowships, which are post-CCT, it gives people an opportunity to work in the so-called deep end practices, those practices that are based in areas of health deprivation. Because if we can really immerse ourselves in the communities and understand why healthcare doesn't get to those communities, we can then design our services and our systems around that and deal with that. In secondary care, a few years ago, we had what we called the immersive experience, where we actually took some of our internal medicine trainees and actually got them working with some of the charities and some of the organisations that work in these more deprived areas. So some of them worked with Nottingham Sexual Violence Support Services, working with victims of sexual violence. Some worked looking with victims of domestic abuse, the homeless, asylum seekers, and rural communities, because of course lots of pressures on rural communities. And as I say, and we had really good feedback on this, it really gave them an understanding, or a beginning of an understanding, of the challenges these communities face. So when they become hospital consultants and they're designing services, they're designing a heart failure service or whatever, they have some of the ability and knowledge to make sure that service reaches all the people that it needs to reach. Better still, of course, if we can give our doctors the skills to lobby for policy change, either nationally, regionally, or locally. And again, that will make a huge improvement in overall health, much more of an improvement than simply treating the patient that sits in front of us. And then there's global health. We've just had an example, 2 examples, global health. But here's another aspect of global health, which is climate change. You know, every time I prescribe an MDI, that's the equivalent to driving a car from London to Manchester and back. So many of our treatments do contribute to climate change. And if we are going to ensure that we make people better without making the planet worse, that's something we really do need to include in our curriculum. And then, of course, there's healthcare in the world of AI. This is an article from that very august scientific journal, The Guardian. But at the end of last year, The Guardian did a whole series on what jobs are going to look like in the world of AI. And this is what it said about healthcare. Morning scramble to a harassed GP receptionist for help. Patients now contact their doctor's AI to explain their ailments. It quickly cross-checks the information against the patient's medical history and provides a pre-diagnosis. And soon, of course, it will provide a diagnosis. So what is the role of the doctor in an age where AI can do so much of what we currently do? Well, first of all, we've got the wider role anyway, don't we, of things like education, research, and leadership. And these skills, I think, are going to be more deeply embedded as curricula as time goes on. But we've also got the kind of humanity of being a person in the world of AI, of being that human link with the patient, whether that's seen as the patient's partner or their advocate or their guide or whatever. We will become that human face. And of course, one way of promoting that, one way of making sure that we can actually provide that is by teaching medical humanities. And there are a lot of medical schools in the States now, about 70, that provide teaching in the arts to medical students. And in fact, we have a few some of our GP APDs here do a lot of teaching around the arts as a way of improving, if you like, the humanity of medicine. As the science of medicine gets more complex, the art of medicine gets more and more important. Interestingly, one of the first medical schools to do this was Harvard, and they introduced a visual arts program. And the purpose of this program was to increase clinical observation. They took a picture like the sick child, they got people to look at it. What can you see in this picture? But they then realized if they took pictures like the one on the left and got people to discuss them, that helped people cope with ambiguity, which of course is a major thing that we need to do as doctors. Pictures like the one on the right of the migrant mother, that really helped people develop empathy and begin to understand some of the feelings and things that patients may have. There's a lot of proof, a lot of studies looking at poetry and medicine. Okay, so poetry has been shown, or study of poetry has been shown to sharpen listening and attentiveness. It's been shown to enable acceptance of ambiguity, enhance empathy, and really important, as the doctor becomes this human link between technology and the patient, it increases an understanding of the experience of illness as opposed to the symptoms of illness. And there's a really important distinction there between the two. This isn't poetry, this is prose, but this lady Ulla Karin Lindqvist, was a anchor on Swedish TV news, and she developed motor neuron disease, and she wrote this book about her experience with motor neuron disease. Now, I'm not going to read this paragraph out, but you can quite imagine, you know, we're very good, aren't we, at measuring symptoms with motor neuron disease. We have grading of muscle weakness, but you can quite imagine, actually, if you read that paragraph and discussed it, you would begin to understand a lot more about the experience of having motor neuron disease than the symptoms of having motor neuron disease. And I think as time goes on, we're already beginning to see it, there's going to be more and more emphasis on this human side of medicine and of humanities teaching in medicine, both at an undergraduate and postgraduate level. And then finally, all of this has to be done interprofessionally. Okay, we provide care as teams, and we should train as teams. We're very good at separating out medical students, nursing students, midwives. In Cambridge, we used to have our lectures with the vets. And I've never quite understand if we could learn with the vets in Cambridge, why we can't learn with the physios or the nurses or the pharmacists elsewhere. And we are actually doing nationally, we're doing some projects in maternity services. So we've got one project being piloted of getting student midwives and student doctors to do ward rounds on the maternity wards together. And we've got another pilot of, again, midwives and medical students going out to the houses of expectant mothers and just seeing them on a regular basis and discussing their care. Okay, so what about how we train? And let's start off by thinking about the consultation. And we've had simulated patients for a long time. There are whole groups of actors that work as patients, and we use them in exams and we use them in teaching. So I'm just going to play, if the technology works, I'm relying on this man here, a conversation between a doctor, trainee doctor, and a trainee GP, I should say, and a simulated patient. Patient's called David, and he has type 2 diabetes. It's an online consultation. There is, I'm afraid, a bit of a gap between the doctor speaking and the patient speaking, but hopefully you'll be able to hear it. Okay, so the reason I play this is not the world's best consultation, but the reason I play this is because this is not an actor. This is AI. This is a chatbot. Okay, and what you can do is you can create your own patient, and you can put any details you like about the patient, and then you can have a consultation with that patient who will behave as described in the description. And just to show you how powerful this is, we've changed this very slightly. We've taken the same patient, but what we've done now is just to insert a sentence saying the patient has just moved to rural Scotland. That's all we've put in, and now look what happens. So you can have you can create your own patient, okay? You can have a consultation with that patient, and you can then take that consultation or recording of that to your educational supervisor who can go through it with you, or actually the software itself gives you feedback. And as you can see here, it doesn't mince its words when it gives feedback. Though interestingly, you can ask it to tone down the feedback and be more gentle if you wanted to. And so, you know, we had libraries of books. We don't need libraries of books and knowledge anymore because that's readily available. Our trainees of the future will have libraries of patients, and they'll have libraries of bespoke patients. Now, I did think about getting someone here to volunteer to do a telephone consultation with David, but I thought that might kind of become a bit chaotic. So instead, you can write this number down afterwards. What you can do is you can phone David on this number. Anyone can do it, and you can practice your consultation skills. And I'll show you that number in the end, just in case you want to have a go. And then, of course, if you put on a virtual reality headset and some virtual reality hand controls, you can actually visit the patient in their house. Here we are. And you can wander around the house, and you can actually look for trip hazards and that type of thing. And you can then examine the patient. So the clinically astute of you may realize this is not Wilfred, this is someone else. But you can listen to their chest. You'll see in a minute, you can kind of listen to the back of your chest, and you can actually hear the heart sounds, hear the breath sounds. Feel their pulse, and you will get the pulse through the handset, and then you can choose what you want to do next and give the treatment that you think is most appropriate, in which case, this case, I think they're going to take some blood, as you can see here. And this is happening now. So this is the largest virtual reality facility outside North America, and this is just round the corner in University of Nottingham Medical School. You can see some students waiting here as the headsets and the handsets come down. They look a bit bored actually, but they are all ready to start their virtual reality session. And then last week we got our educators to all have a go. So we promote this technology for postgraduate education. They're looking a little bit more enthusiastic. This is our radiology academy. So one of the things about procedural specialties is that when you first start, you don't provide much of a service. In fact, you're a bit of a distraction because people are going to having to slow down the clinical service so they can train you. So what we do with our academies for things that we've got two at the moment, we've got one for radiology and one for endoscopy, is in their first year, our resident doctors spend a large amount of time in these academies so that they can interpret scans, they can have a go on the various fairly sophisticated simulators that you can see here. So by the time they hit the ward, they've got that basic kind of knowledge and appreciation, and that allows them to learn a lot quicker. I really like the thing on the right. This is an interesting piece of software. So obviously the resident doctor will sit here and interpret the scans that are on the screen. But what this software does is it tracks their eye movements. So once they've interpreted the scan, they get a map of which bits of the scan they've looked at and which bits of the scan they missed. So a really good example of how technology can do something you can't do otherwise and really get people into good habits at the very beginning. This is our endoscopy suite academy. This is in Birmingham, but we got them scattered around the region. And again, it means people don't have to start learning from scratch and slow down the list. They can really get up to speed in an immersive environment and then actually develop a lot faster when they hit the clinical arena. This is not, these pictures are not taken during operation. This is 3D printing. So this is 3D printing done by Nottingham and Trent University. This is the operating theatre in Nottingham and Trent University. And next month, our School of Surgery is running an operating course using 3D printed models in that operating theatre. Another example of how technology can change training. Simulation, of course, is a really important part of training. This is the simulator that's been around for quite some time over at the Queen's campus. It's now fairly out of date. The modern simulators project images around you. So as you can see here on the right, you really feel that you're in someone's room. Nottingham Medical School is about to open a 8 simulation suite facility where actually you can create smells, not just images, but you can create smells. So avoid the Melina simulation, I would, but and Lives, which is the charity that does pre-hospital care, is raising money for simulators that can make it rain and can make it snow. Okay, that's the level of sophistication of simulation. And technology enhanced training has lots of advantages. So first of all, it can be planned. Clinical training is not planned, is it? It's opportunistic. It's based on what comes in next through the door. Simulation, technology enhanced training, whether it's the kind of AI stuff we saw at the beginning, or whether it's stuff done through virtual reality, can be planned, can be repeated lots of times. So the obvious example is the Endoscopy Academy, where you can just simply repeat and repeat and repeat until you get it right, but also really good for drills. You know, if someone's having an uncontrolled seizure, actually you learn far quicker and far more treating it as part of a virtual reality scenario than you would do from reading it from a book. You know, you do really get the adrenaline, actually. You do really feel they're there, and you can repeat it and repeat it and repeat it until you're sure you got it right. Allows you to develop technical and non-technical skills. Very importantly, allows you to fail and allows you to experiment, which is really important. It allows you to explore difficult or rare situations. So the 3D printing is a really good example where they can, you know, produce models of rare anatomy or very rare pathology. Multi-professional, it's a really good instrument for multi-professional saving, multi-professional teaching. And some of it can save money. I mean, obviously the simulation's expensive, that stuff's expensive, but the AI stuff we saw at the beginning, the chatbot, it's actually a lot cheaper than employing actors. So putting this all together, what will medical training look like in 2040? Well, I think we're likely to see different entry routes into medicine. We are not likely to see much more flexible postgraduate training programs. I think that's going to be in the next few years. Greater focus, not just on the patient, but on community and global health, and on some of what people call softer skills, leadership, education, and research. Probably a greater emphasis on humanities teaching, because it's that human bit that we'll be bringing to the party, if you like. And the technology of training will change. So at the moment, we're sitting in a postgraduate centre. Maybe in 2040, the postgraduate centre will look like this. Okay, it'll be a postgraduate learning centre. There'll be a 3D printing suite. There'll be a simulated operating suite, a virtual reality room. There's no lecture theatre on that map, but I'm sure there will be lecture theatre, and I'm absolutely sure that MedChi will still be meeting in that lecture theatre in 2040. So I'm going to finish there. Thank you very much. And there's David's phone number if you want to give him a ring. Yes.
So Jonathan's happy to take 1 or 2 questions if anyone wants to. Tony.
Great presentation. What was it that's happened in the East Midlands to make a difference in terms of the GP training?
So the person sitting two seats away from you, but it's the emphasis on getting people through their exams. It's made a difference, and that's about identifying people early. And you've got a system, haven't you, for actually spotting those people who like to run with their exams. And it's about the method of training. So it's about blended learning, which allows you to actually, it gives you the capacity to actually train people to get through the exam. So that's a lot of it. Yeah. I mean, our pass rate this year, so the national pass rate, I'm going to get this wrong, it's about 61%. Our pass rate, I think, about 79, 82%. And that is with a much higher proportion of international medical graduates that tend to do less well in exams. So that's how effective it's been. Julie.
Conversely, they all wanted them straight pay rises and doctors.
So I think it's complicated. So the moving to Australia is partly about pay, but it's partly about the other conditions that our doctors face, and it's partly about training. Okay, so this is what the medical training review is doing, and making training much more flexible, I think, is going to be an important part of it. The other thing is we haven't got the very basics right, and that's what the so-called 10-point plan is about. So, you know, things like, can you park your car when you're on call? Can you get a hot meal in the hospital? Is your salary going to be correct? Or are you going to be asked in a few months' time to pay back 10,000 because it's been wrong? These are all the things that we're working really hard now, because actually it's not just pay, it's all these other things as well. A lot of the people who go to Australia come back. Some don't, but a lot do. Yeah, well, very luckily, that's the government. I kind of thought that one out, not me. But it's difficult, you're right. Yeah.
It's a problem beyond training, isn't it? It's a problem of resourcing.
Yeah.
It's a lot about. I don't want it to be a bottleneck when I want a consultant job as well, but you can't just pay for lots more consultants than lots of everything else. So,
Having done an Ofsted in Australia, for obstetric training, I can tell you their training works now.
Yeah.
Really not factual.
Yeah.
But my question is about simulation. I think simulation is something we've been doing for a long time. But for me, a successful simulation session is about the precepting.
Yeah,
absolutely. You need the engagement of your clinicians. You can't just give somebody a box trainer and send them home with them stage for them to do a laparoscopic hysterectomy. Somebody needs to be there with them.
Yeah, absolutely.
And it's about mental time.
Yeah.
Most medical education is being done by people in their own time.
Yeah.
And okay for a very long time, but I don't think we've recognised our educators.
Yeah, we certainly haven't recognised our educators. Actually, for those of you that do work in hospitals, the new job planning guidance is much better when it comes to educators and recognising educators. But there is something I call the fantasy PA, which is someone who's allocated time in their job plan, but actually they just move other stuff into the evening and do the educational supervision during the day. And I think that's well recognised. I think similar, you're absolutely right about simulation, but I think one of the advantages of some of these new technologies is you can do stuff outside the simulated environment, you can do stuff at home, or you can do stuff yourself. That's not going to teach you everything, but it will be a start that actually then, if anything, makes the simulation even more valuable. And the other thing to say about simulation is a lot of it's about human factors. So you've got the simulation of doing an operation, but actually what's much more powerful in simulation is teamwork, the way people speak to each other, and those kind of human factors. We're doing a lot of work, or we did do a lot of work with some British Airways pilots who really helped us develop simulation.
yeah.
I thought you would, because you read that report, yeah.
And that's national data. Said that our intake, our special criteria to set, and it's higher than. So, I don't know the lessons, but I imagine, they've got a program. I imagine it might be similar. So I suspect that the biggest reason is.
I think you're right.
Better.
Yeah, I think you're right. And I think Leicester's, from what I remember, very similar to Nottingham's, and they're very. And the other thing about their widening participation institutes, I don't know if it's the same in yours, is that they do tend to stay in the areas where they grew up, which is really, really important.
And that's what we think.
Yeah, yeah. And actually, that's the evidence from Canada and Australia and places to say that if you recruit these people into medical, they then tend to go back to their communities. I think you're right. I think probably East Midlands is doing better than most areas. And the other thing to say, although that line is about straight at 6%, the number of applications has gone up from lower socioeconomic groups, which is the start.
But actually, a lot of the GP registrars in other, parts of the country have slightly different models. And actually the feedback from them is poorer. So I just wondered what sort of renewed the national aid on the policy would be to standardise things to make sure that that's not actually disadvantaging some people who are start looking through C-level modules and not really getting the intensive educational support that I think to help these women.
Yeah, actually, I have to get the blended learning right. So there's a model we use, which is around exams, but there's another model, I can't remember, Sarah remind me which region it is, where they use the blended learning for more clinical stuff. And actually, the GP resident doctors there have very, very positive feedback. So I think you're right, it's about getting it right. And there's no point in it's not being done as a way of saving money, it's being done as a way of increasing the effectiveness of teaching. That's the key thing.
Good.
Engineering been trying. They back, they took a whole load of numbers on anesthetics, go to general practice and psychiatry. So, because they thought that people who wanted to be anaesthetists would make CEOs of countries. Funny enough, they don't. So what they ended up doing was creating career blockages in anesthesia, and these guys virtually presenting.
Yeah. So this
We're going to have it for routine.
No.
Got to get people actually do general practice.
Yes. And there are enough people, and in fact, competition ratios, even if you exclude international medical graduates, suggest there are enough people. The redistribution of NTNs happening over the last few years is about a regional redistribution. So it's not about converting anaesthetics to something else. It's about taking anaesthetic training posts in London and moving them to places like the East Midlands, because there are huge disparities in training numbers. And what we do know also is that if you train in a region, you're much more likely to stay in that region. So it's really an effort to engineer a greater supply of consultants in the underserved areas.
I'd like to ask, time is pressing on, so we probably better finish. It's fascinating, absolutely brilliant talk, Jonathan. Jane Selwyn's going to propose a vote of thanks to Jonathan.
Thank you very, very much, John. Really inspiration, in fact. But I'm older than you. I'm way retrained, way back in the dark ages. We've just come so far, I can't believe it. Before we came in this evening, I spread a few bullet points down that there was a few things that I thought about. Service provision, inflexibility, super specialisation versus generalists, AI technology, the European Working Directive, the rise of real teams, the firms that used to be, medical student selection. I think we've covered every single one of those points and a lot more. So thank you very much indeed. And I'll just say, I studied humanities at A level, and I did first MD, so it's a 6-year medical degree, and the name is here. So I'm absolutely delighted to be focused on that. But thank you very much.